Now we are going to talk about the specific subtypes of non-Hodgkin lymphoma. Let's talk about marginal lymphomas. The marginal lymphoma originated from the region between lymphoid follicles and mantle zone. It belongs to B-cell lymphoma, indolent lymphoma. The immunophenotype is positive for B-cell markers, CD19, CD20, CD22, negative for CD5, CD10, and usually CD23. The marginal zone lymphomas encompass 3 clinical presentations, including nodule marginal zone, splenic marginal zone, and extranodal with masses in the respiratory or gastrointestinal system. Nodal marginal zone lymphomas do not differ from follicular lymphomas with regard to clinical presentation, outcome, and management. As for patients with mild tumors, sites of presentation include the gastrointestinal tract, especially the stomach, and also salivary glands, skin, lung, thyroid, and oblique. Gastric mark lymphoma commonly presents with symptoms of dyspepsia, anorexia, epigastric pain, and gastrointestinal bleeding. Its pathogenesis is related to Helicobacter pylori infection, and 70% of cases will show regression of the tumor with irradiation of Helicobacter pylori. Using combined antibiotic and antacid therapy, this has led to the use of antibiotic and acid blockade as first-line therapy. Splenic marginal zone lymphoma appears to be another distinct entity, although much less commonly. Interestingly, some splenic marginal zone lymphomas have been recognized to arise from chronic antigen stimulation, such as with HCV infection, and treatment directly at the virus may lead to regression of the lymphoma. No constant or unique chromosome abnormalities have been reported. Mantle cell lymphoma is recognized by definitive histology and immunogenetic features. Malignant cells arise from the mantle zone or perifollicular area and present as small to medium-sized lymphocytes with a round, irregular nucleus, which is sometimes cleaved. This lymphoma is characterized immunophenotypically by the presence of CD5, but unlike CLL, it does not express CD23. Most mantle cell lymphomas have a translocation of 11 and 14 that involves the BCL1 proto-oncogene strongly expressed cyclin D1 mRNA by RT-PCR, even in translocation of 11 and 14 negative cases. Many patients present with a disseminated illness with a leukemic spread at diagnosis, resulting in possible confusion with CLL. Although considered a relatively indolent lymphoma, the mantle cell lymphoma responds poorly to treatment and has a median survival of only 3 to 4 years, much less than most CLL patients. A blastic variant has an even poorer prognosis and is frequently associated with the central nervous system infiltration and neurologic symptoms. When immunophenotypic analysis is unable to distinguish CLL from mantle cell lymphoma, Cyclin D1 and translocation of 11 and 14 analysis are required. As techniques for diagnosing clonal lymphoid malignancies have improved, especially the ability to detect rearrangements of B or T cell antigen receptor genes, an increasing number of tumors of T cell origin have been identified. Clinical clues to the presence of a T cell malignancy include the presence of lymphadenopathy, constitutional symptoms, leukopenia, or aplastic anemia, disseminated disease with bone marrow involvement, hepatosplenomegaly, lung and skin involvement. The ultimate diagnosis of a T cell lymphoma requires study of cell surface markers and T cell receptor gene rearrangement. The latter is the only certain way of proving a clonal orange for T cells, since a normal T cell immunophenotype occurs in many T cell non-Hodgkin lymphomas. Many T cell lymphomas are characterized by a pleomorphic cell population. Most of the time, they are diffuse, small or large cell non-Hodgkin lymphomas with the phenotype of mature T cells, often including large numbers of macrophages. This diverse cell population is probably recruited to the site of the tumor by production of cytokines by the malignant T cells. In addition, production of these cytokines explains the common occurrence of inflammatory signs and symptoms. The most common T cell lymphoma are listed here. The first one is the immunoblastic T cell lymphoma. It is a disease of the elderly, accounting for 4 to 6% of all lymphomas. Patients present with generalized lymphadenopathy, hepatosplenomegaly, skin rashes, arthritis, pleural effusions, and constitutional symptoms. Patients may suffer from Coombs-positive hemolytic anemia or thrombocytopenia, and the EBV gene is included in nearly 100% of lymph node T cells. The cause of the disease is aggressive. The second one is anaplastic large cell lymphoma. This variety of lymphoma accounts for 2 to 3% of all non-Hodgkin lymphomas. Malignant cells are large, undifferentiated anaplastic cells, which have sometimes been confused in the past with red Sternberg cells of Hodgkin lymphoma. Anaplastic large cell lymphoma has two different presentations, differing in their expression of the ALK kinase. ALK positive cases present in young men with lymphadenopathy and extranodal size, as well as constitutional symptoms, and have a better prognosis. Whereas ALK negative cases present in the 6th decade and have less extranodal involvement but a poor outcome. The third one is peripheral T cell lymphoma unspecific. This variety is the most frequent type of T cell non-Hodgkin lymphoma in Western countries, accounting for 5 to 7% of all non-Hodgkin lymphomas. It presents in elderly patients with bulky lymphadenopathy, constitutional symptoms, and usually disseminated disease. The proliferation cells are pleomorphic, varying from small cleaved cells to large immunoblastic ones. P53 mutation is considered to be related with a poor prognosis in some cases. That's all. Thank you.